This evening, I want to remind you again that my name is Gladys, and I'm going to take you through pharmacology. We have been having health assessment, but basically today we are going to handle pharmacology. So, in relation to this module of pharmacology, we are basically starting with cardiac failure, which is one of the conditions that is common. And here I want to start with the objectives of this topic. So the first objective is basically to define heart failure and its causes, types, and the stages. And we also need to explain the pathophysiology of heart failure and how it affects the cardiac function, and then identify the signs and symptoms because each condition has its signs and symptoms. We very well know that. So also the heart failure condition has its signs and symptoms and the diagnostic tests that can be used to confirm it. Then we have to describe the pharmacological management of heart failure, including the classes, indications, mechanisms, adverse effects, and interactions of commonly used drugs. And lastly, we have to apply the principles of evidence-based practice, patient education, and the safety. So here we start. Heart failure refers to a condition where the heart cannot pump blood. We very well know that the heart, its function is basically to pump blood throughout our bodies. So in this condition, the heart fails to pump blood efficiently to meet the body's needs. Our body's activities are actually based on the heart. So if the heart fails to function well, then it is going to affect the body's needs, resulting in symptoms such as shortness of breath, fatigue, and fluid retention. So fluid retention may lead to edema. You find somebody's legs are swollen, the face is swollen, and can be generalized everywhere. Then for the case of shortness of breath, we all know the circulatory system is also related to the respiratory system in one way or the other. So that's where you realize the patient presents with that. So the common causes of heart failure, one, it can be impaired cardiac function, and the conditions like cardiomyopathies, myocarditis, the coronary insufficiencies can be some of the causes. So the myocardium is actually the muscles within the heart when they get inflamed. That's why they call myocarditis. And then others are just conditions that can affect the different parts or the structures of the heart. Then also it can be excess work demands, whereby there is systemic or pulmonary hypertension, then valvular heart diseases, and congenital heart defects. Impaired cardiac function can be also conditions like cardiomyopathies, myocarditis, insufficiencies. Basically, this has been mentioned in the previous slide. Maybe to say something on myocardial diseases, these ones include cardiomyopathies, myocarditis, and so forth. So the valvular heart diseases, this is stenotic or regurgitant kind of valvulations affecting the cardiac function. And this one is basically in relation to the valves of the heart open when the blood comes into the heart. It has to open and close. But then if there is a problem with these valves whereby they may fail to open or they fail to close, then you realize that a person can get a condition in relation to the valves of the heart leading to valvular heart conditions. Congenital heart diseases are also some of the diseases that can affect the functioning of our hearts, and basically looking at the structural abnormalities that are present from birth affecting the heart function. And you get this basically in relation to the newborns, whereby the heart can fail to close, all the valves get a problem, and these babies can come up with the defects in the hearts and causes some conditions or congenital heart diseases. Then some are disorders that are related to contractility. Contractility is basically how the heart contracts the muscles of the heart, the myocardium, has to contract in order for it to release what it contains, basically looking at the blood. And this can be due to ischemia. When there is ischemia within those muscles, it can also fail it to contract. Then hypoxia, acidosis, inflammation, and also accumulation of toxins and some other metabolic disorders can all impair the cardiac contractility. And this will lead to heart conditions, hence heart failure. Coronary heart disease, hypertension, this is basically in relation to the adults, idiopathic dilated cardiomyopathies. There are some cardiomyopathies that can occur and you may not understand what could be the cause. So that's why they say idiopathic. Idiopathic is like unknown. And then the valvular heart diseases, which I've mentioned already, failure of the valves to function normally in relation to the different chambers and the different blood vessels within the heart. Then there can be diabetic cardiomyopathies, which can also affect the functioning of the heart. And the cardiac output can also be one of the causes in relation to the heart failure in adults. So cardiac output is basically the amount of blood that is pumped by the heart in 1 minute. So when you look at the amount of blood that the heart pumps in 1 minute, that is called the cardiac output. And it is calculated by multiplying the heart rate, those are the beats per minute, by stroke volume, which is the volume of blood that is pumped out. So the number of beats per minute and the amount of blood that is released at that time will give us the cardiac output. So when you look at this cardiac output and control, this basically is trying to tell us how the heart releases blood out of it. So the cardiac output, where is the blood coming from and which part releases the blood? So when you look at the heart, you have to know the functions of the heart and you have to understand the structures of the heart. So when you look at this, you see that the cardiac output, blood is released from the heart, and when the blood is released from the heart, that is from the left atrium, the blood enters into the ventricle and is pumped out into the entire body. So even the renal system, as we mentioned earlier on, there are different structures that are related, or the different systems that are related with the circulatory system. So the renal system is one of them, which is the urinary system, as people love to call it. So it's also one of the systems that is responsible for the heart. So when you look at this, it is responsible it functions almost in relation to the heart or in relation to the circulatory system. So the blood is pumped out of the heart, or there is cardiac output, and this blood goes into the renal blood flow, whereby it goes to the kidneys, and from the kidneys you realize that there is production of some chemical, and that is the renin-angiotensin-aldosterone mechanism occurs due to the production of blood, or the release of the blood into the kidneys. So when the kidneys don't get enough perfusion, it will cause a problem. So the heart, or the cardiac output, has to be actually adequate enough to maintain the renal system. So when there is when there is cardiac output which is enough, you realize that the blood is released into the kidneys, and from the kidneys there can be release of salts and water, whereby there is retention. Water causes retention. So there can be retention of salts and water, and then also there is vascular volume will be also increased. Then there will be venous return back to the heart. But when there is no good cardiac output, then there will be no proper venous return to the heart, and yet the circulatory system has to continue in the same way for us to realize the normal demand into the other parts of the body. So our bodies function basically when there is good functioning of our hearts, and when there is good cardiac outflow. So in case there is little cardiac output, that means that even the fluids or the blood that gets into the liver, that gets into the kidneys to function well in the renal system will be affected. So from the renal system, there can be production of this renin-angiotensin aldosterone mechanism will take place, whereby there is production of that angiotensin kind of chemical, which will release angiotensin 2. And in this case, this aldosterone will be also produced from the angiotensin 2, then it goes back to the kidneys. And this is very key for our bodies to function. But if there is no production of this, then there will be an issue. So angiotensin 2 can also act onto the blood vessels, then to stimulate the vascular tone. And in the vascular tone, it may help us uh, to help in the formation of other chemicals again. And in case there is a problem which will occur in the circulatory system, it will always affect the functioning or the flow of blood through the blood vessels. So for this case, if there is decreased production of if there is decreased outflow of blood to the kidneys, it will always lead to the production of these chemicals, which will affect the flow of blood through the blood vessels, and will lead to the vascular resistance, whereby there will be a lot of resistance for the blood to pass through the blood vessels. And in that case, it will also affect the heart, because if there is that resistance, it will also lead to the resistance directly onto the heart chambers. So this will affect the cardiac output, and will also affect the input of blood into the heart. So there should be a good control, and this can only be in relation to the cardiac output. When there is poor cardiac output, that means there will also be poor flow of blood throughout the rest of the systems in the body. So the heart has a big role to play in relation to so many things affecting, and so many things that contribute to the good outcome of different activities in our bodies. So we need to look at this very critical, and we need to understand that cardiac output and control is very, very key in relation to our hearts or our bodies to function. When the heart does not function well, that will affect the renal system, and in case there is any problem in the renal system, it will also affect the heart. And in case there is a problem with the pulmonary system, it will always also backfire on the rest of the systems. So these systems work hand in hand, and there is need for us to understand that. When we don't understand the structures of the heart, then it is going to also affect, or it will also make us not to understand how the cardiac output and its control can be handled or can be managed. So when you look at this, you just realize that cardiac output is the controller of each and everything. So when the blood actually accumulates on these ventricles, then it will now cause them to expand. That is now myocardial hypertrophy, where the heart becomes enlarged. And that is when people always say that they have said they have a large heart, just because the heart fails to pump. So there will be decreased cardiac output, and when there is decreased cardiac output, there will be little perfusion to the kidneys. And when there is little perfusion to the kidneys, it will always affect the other parts of the body to receive enough blood. So when it happens in that way, then someone can end up having edema, someone can end up having a congestive heart failure, and someone can also end up having a problem in his lungs. So there are so many things that can come about in relation to heart failure. It is just a syndrome. A syndrome is basically a kind of a collection of different signs and symptoms. So we have to understand what happens in case there is poor cardiac output, what happens if the cardiac output is adequate, but then the other systems, the lungs, and then the kidneys are not functioning, or the blood vessels. So even the blood vessels contribute a lot in relation to the cardiac output. So all these things have to be looked at in order for you to understand what a cardiac output and control in relation to heart failure. So cardiac output and control, basically to explain in this slide, cardiac output is basically the heart rate times the stroke volume. So the heart rate is controlled by the autonomic nervous system and the hormonal factors, while the stroke volume is influenced by the preload, afterload, and contractility. Contractility is basically the ability of the heart also a problem, or there'll be a defect in the cardiac what? In the cardiac output. So we have to look at all this, and we shall get to understand what happens in relation to poor contractility. Kind of force in them, whereby they do not empty completely the blood which is in it in order to receive the next refill. So they still have some little blood that keeps that even in order to receive the next blood that will be pumped into them. So that is what the preload is. Then afterload is releasing, and when it releases, it still has some pressure in it to maintain that kind of the strength, and also to keep the ventricles and the ventricles open in order to release, so they don't empty completely the blood that enters in them. So we need to understand what happens in the preload. We need to also understand what happens in the afterload. So preload, it's just the force that stretches the cardiac muscle before or prior to its contraction. So it is just that force that keeps it open, or it is a composition of just the volume that fills the heart from the venous return. So the venous return is when the blood comes back from the system into the what? Into the heart, so that it can be pumped back into the lungs for it to be oxygenated. Then the afterload is just the stretching. Afterload is basically the stretch of that myocardium, or the end diastolic volume of the ventricles, and is most frequent basically when there is a volume of maybe some blood that is before the distal. That is the what? That is the afterload. So we need to understand this critically, so that we can be able to explain that when there is cardiac output, this happens as the preload. When there is cardiac output, this happens as the afterload. And then contractility, what does it mean? So control of the heart rate is automatic, and that's where they say that is controlled by the autonomic nervous system, which is the sympathetic and the parasympathetic branches, and the hormonal control. And the hormones that are basically responsible to control the heart rate is the adrenaline and noradrenaline. So those hormones are produced by the nervous system, and is basically the autonomic nervous system in relation to the sympathetic and parasympathetic branches of the nervous system. So it also the control of this sympathetic nerves is basically in relation to the preload, whereby the volume of the blood in the heart, that is the volume of the blood in the heart before contraction. And I actually mentioned it, what a preload is. Preload is basically the volume of the blood in the heart, but that is before the contraction. Then after is the resistance the heart must overcome to eject or to release blood. And the contractility is the strength of the heart muscle contraction, and that is the myocardium. So the myocardial muscles are basically the ones that are responsible for contractility. in the heart. So when it helps to contract, then it will be helping actually to release or to eject the blood out of the chambers of the heart, either to the entire body if it is from the left ventricle, or it will be to the lungs for it to be oxygenated if it is from the right ventricle. Then the preload, here we are trying to explain it further, that preload refers to the stretching of the myocardial fibers during the distal. And the distal is relaxation phase of the heart cycle. So the heart cycle for the heart to complete is for it to pump out and receive. So this increases the end distal volume, and then also it consequently um, contracts during the systole. So contraction phase of the heart cycle is the force of contraction during the systole, according to Starling's law. So the Starling's law is also very important for us to understand. It is a law that helps us in knowing what happens in the heart, and helps also in relation to maintaining the functioning of the heart. So when this law is not maintained, then it will affect um, the functioning, or it will affect the way the heart is actually functioning. So this law states that the stroke volume of the left ventricle will always increase as the left ventricle increases due to the myocyte stretch, or these cells when they stretch from the myocardium. It will always cause a more forceful systolic contraction. So the systolic contraction is basically what we call the systole. So this law of the Starling's findings is very key in order to maintain the functioning of the heart. So what could be the factors affecting the preload? The factors that can affect the preload can be the venous return to the heart, which determines the EDV, and while the stretching of the actin myosin bridges within the heart muscle influences force development during contraction. So these muscles are actually responsible for the heart to contract. So when these muscles cannot stretch, that means even the heart cannot what? Contract. So the myosin bridges is just like a combination of different muscles that help in the stretching of the heart. So disorders related to the preload. What could be the disorders that can be related to the preload? Too high preload can lead to overstretching of the sarcomeres. Sarcomeres are also some cells that are found in the myocardium, and the myocardium is basically the muscles of the heart. So the sarcomeres and a decreased strength of contraction, when the muscles of the heart cannot contract, or they contract but the pressure, or the ability of them contracting is very low, or it is weak, that's what can lead to some of the disorders in preload. While also too low preload can result in decreased sarcomere length and also reduced contractile strength. So when there is also little pressure or little flow of blood into this ventricle, it can also lead to that decreased sarcomere length and also reduced contractile strength. So this works hand in hand. The decrease on the other side affects the functioning of this one, and vice versa. Afterload also refers to the resistance the heart must overcome to eject blood during systole. And primarily it is determined by the pressure in the left ventricles, the aorta, and the right ventricles, that is the pulmonary arteries. So all this works hand in hand, but if there is any kind of resistance in relation to this, I mean failure of this the ventricles to resist during this time, then it will cause a problem to the heart in relation to afterload. So this heart must be able to overcome in order to eject the blood during this systole phase. So when you look at the pathway of how the heart failure develops, there are so many things which happen. There's production of renin, angiotensin. There is also formation of the aldosterone antagonist, and there is also kind of some other factors which can be in relation to the blood vessels. So when you look at this, you can start from anywhere, but I want to say that let's start from the renin production, and we can see that the sympathetic activities, and we said the heart is controlled by the autonomic nervous system, where you find the sympathetic and the parasympathetic nerves, and these nerves always end up producing some of the hormones that are responsible to control the functioning of the heart. So the sympathetic activity can take place, and there will be kind of cause of the vasoconstriction of the blood vessels. And in case there is no vasodilatation, that will also lead to some kind of effect onto the blood vessels or onto the valves of the heart. Then when there is vasoconstriction, it will affect the release of the blood through the blood vessels, and this can lead to actually little perfusion into the kidneys, and for that case it will lead to little input back to the what back to the heart. So when you look at this, vasoconstriction will affect the supply of blood to the different vital organs if it is from the left ventricle. But in case it is from the right ventricle, then you realize that there will be little release of blood into the lungs for it to get perfused, in order for it to come back to the to the left ventricle, for it to be dispatched or pumped to the rest of the body. So all this can affect. So vasoconstriction, there will be afterload. Then from the afterload, there can be myocardial oxygen demand. In case there is little afterload, it will not allow enough blood to get into the ventricle, and for that case there will be little blood pumped out, and can lead to myocardial oxygen demand, because what is gotten into the heart is little, and it's having little oxygen, which will also affect the myocardial muscles to function well, in order to pump blood out of the heart and straight to receive from either the lungs, for it to pump it into the rest of the body. So when there is that effect on these myocardial muscles, that there is no oxygen, it will be demanding oxygen. So when there is little oxygen onto the myocardial muscles or the muscles of the heart, it will now affect the heart from functioning. The heart will fail to pump out, and when it fails to pump out or to release a good cardiac output, then it will affect the heart and cause heart failure. Then also you can look at this side of the renin. In case of the sympathetic activity, there can be production of renin, and this renin can release renin angiotensin 2, which is also a chemical which can cause the production of aldosterone, and this aldosterone can lead to the production of the retention of sodium into the blood vessels, into the kidneys, into the tissues. And when there is retention of sodium in our bodies, to lead to accumulation of fluids. And when there is accumulation of fluids in the body, it will cause edema, because now the kidneys have failed and the kidneys need perfusion, but there is little blood released from the heart. That means the kidneys also will fail to function, and there will be retention of sodium ions in the body, which will cause actual attraction of fluids, and you end up having edema. And in this case, when there is no antidiuretics given for this person to help release or pass out the fluids, the person will end up accumulating this into the tissues, which will cause vascular volume to increase. And when there is increased volume, it will also increase a lot of pressure. And when there is poor preload, then it will also lead to a worsening of the heart, causing heart failure. So there are so many factors that can contribute to heart failure, both in relation to the cardiac output in relation to other systems that are responsible or that function together with the heart, and this will cause a cardiac failure. So many factors come in. So failing of the heart also in releasing the blood, and the blood which it releases can remain in the what, in the ventricles, and when it accumulates in the ventricles may fail to accommodate, and the heart will try to make a compensatory mechanism which will end up making the ventricles to expand, trying to thicken in order to pump, but when it fails it will end up with heart being a compensatory mechanism whereby there will be increased myocardial contractility for it to try to contract, to release blood out of it in order to meet the body's demands. But then if it fails, then there will be increased cardiac there will be increased cardiac workload, whereby the heart now tries to function extremely beyond what it has been function the way it has been functioning, and it will cause the cells to stretch due to that cardiac or workload. And when the cells stretch, there will be also compensatory hypertrophy of the heart and the dilatation of the heart blood vessels and also its chambers, because it is trying to function the way that it was not functioning before this kind of a right ventricular failure. Then also the other thing can be in relation to the left ventricular failure. It will also try to compensate when there is failure of the ventricles to function on the left hand side. It will try like to compensate its mechanism. But because of it failing, because the heart already has a problem, it will now lead to the activation of the norepinephrine and also the atrial kind of natriuretic peptide, which will cause a tachycardia, and tachycardia is increased heart rate. So when there is increased heart rate, it will further stretch, leading to some stress on the myocardium, and the myocardium is basically the muscles of the heart, and this one can cause especially congestive cardiac failure, that is on the left ventricle, because it has failed to pump out, and there will be increased flow. Actually, there will be a lot of blood that is not being pumped out, and this will cause congestive cardiac failure. But also another cause can be compensatory mechanism in relation to the left ventricle failure and the right ventricle failure. Both of them can lead to activation of the renin, angiotensin, and aldosterone mechanism, whereby it will now lead to the production of renin, angiotensin, angiotensinogens, and due to this, it will lead to increased retention of sodium, which will also attract the retention of water, and this will cause further stretching or stress onto the myocardium, which will also cause congestive cardiac failure. So when you look at all this, it is just because the left ventricle and the right ventricle, when they fail, they all contribute to heart failure. So for the case of the right ventricle, when it tries to compensate, it will lead to increased myocardial contraction. The heart will try its best to contract, but it may not be able to contract further. Then it will lead to cardiac workload, increased cardiac workload. Not just cardiac workload, but there will be increased cardiac workload. Then the cells will stretch, the cells of the heart, the myocardial cells. Then it will lead to compensatory hypertrophy and dilatation. So the compensatory hypertrophy is basically the heart tries to increase in size, and that's where sometimes our clients tell us that my heart is said to have enlarged or it is big, because the heart is trying to compensate. So those muscles around the chambers try to thicken in order for it to actually be able to meet the body's demand in contraction. But still, when it fails, it ends up dilating. So when it dilates, then now it fails to contract, and this can lead to heart failure. we also have the different types of heart failure, and these different types of the heart failure. One of them is this you're seeing, high output or low output failure, and this one is actually a rare one. The major ones are left and the right heart failure, which I've already tried to explain to us. So when you look at this high output or low output failure, this condition is rare. Most of our clients it, but in case sometimes they present with or increased, little output. So the high output failure occurs when the heart cannot and meet increased metabolic demands. So that's when it tries now to increase the output, trying to pump out, and yet it is still not able to meet and ends up with this kind of heart failure, because it has been trying to meet the body's or the metabolic demands. So at the same time, low output failure is caused by disorders that impair the heart pumping ability. So the low output is basically where the heart just pumps little. There is little amount of blood that the heart is able to pump, and can be due to different conditions that could have affected either the contractility or also the valves of the heart. So systolic or diastolic function. Systolic dysfunction involves the defects in the ventricular contractions. So this one occurs the systolic or diastolic dysfunction. For them, they occur due to the defects that actually involve the ventricular kind of contraction. If the ventricles do not contract, then it leads to decreased ejection fraction. Ejection fraction is releasing for it to pump out whether oxygenated or deoxygenated blood. But so long as it is ejecting, that is what it means, releasing blood out of the ventricles or the chambers. While diastolic dysfunction involves impaired ventricular filling. So for diastolic, it's basically filling. Systolic is releasing or ejecting, leading to reduced stroke volume. Reduced stroke volume is basically how much it is able to release. So this can affect the heart and cause heart failure. So some of these things are not basically just looking at maybe the heart muscles and so forth, but you also have to look at the different activities which happen within the human heart. Then the left stroke, right stroke left heart failure. The right heart failure impairs the ability to move the oxygenated blood. And when you look at the heart, I believe we have always seen the anatomy of the heart, and we have gone through the anatomy of the heart. And for you to understand more the functioning of the heart, then you should also be understanding the anatomy of the heart. So the right or the left heart failure, right heart failure impairs the ability to move the oxygenated blood from the systemic to the pulmonary circulation leading to systemic congestion. Left heart failure impairs the blood pumping from the pulmonary circulation to the systemic circulation, leading to pulmonary congestion. So when you look at this kind of heart failure, it is talking about the functions of the different chambers of the heart, the left and the right. So when you look at the right heart failure, it is talking about the functions of the different chambers of the heart. The left and the right. So when you look at the right heart failure, the right having the right ventricle, and the right ventricle, its purpose is to receive the deoxygenated blood which has been sent from the different parts of the body, and is supposed to be sent actually to the pulmonary circulation, to the lungs, for it to be oxygenated. But then when it fails to pump that blood the amount that is expected, then it can lead to pulmonary failure, and can also lead to congestion, systemic congestion. Then in case there is also left heart failure, we very well know on the left heart we always receive the oxygenated blood from the pulmonary circulation. So the pulmonary circulation is the one that gives us a blood into the left ventricle, which is already oxygenated. It has enough oxygen. So the left ventricle is supposed to pump that blood throughout the aorta into the rest of the body for perfusion. But then it happens when the pulmonary circulation fails, when it fails, in case it fails to release blood to the lungs or the pulmonary system, our circulation for oxygenation. So all these things we need to understand. What does the left heart receive? What kind of blood? What is its where does it pump it to? And then also we need to understand what kind of blood is in the left heart, and in case it receives blood, where does it pump? When it fails, what happens? So when there is left heart failure, it will also lead to pulmonary congestion, while on the other side it will lead to systemic congestion. So all these things we need to understand. When the heart fails on the left, what happens to the body? Which part is affected? When it fails on the right, what happens? So that we can be able to understand the different types of heart failure in relation to the functioning of the heart in different parts of the heart. So right heart failure, accumulation of blood in the systemic venous circulation leads to peripheral edema, hypo. It also leads to hepatomegaly and other signs of systemic congestion. So when you look at this means the liver will be affected. The other parts of the body will be affected, like edema in the peripheries, which is maybe on the limbs. Someone finds that he is having facial perfusion because the face is having a lot of edema and so forth. So all this is when the right heart fails. Then you realize somebody is having all these kind of congestions in the system, in the liver, in the peripheries, because there has been accumulation of fluids in those areas. Then the left heart failure, it results in congestion of the pulmonary circulation, leading to symptoms such as tachycardia, dyspnea, and pulmonary edema. So the pulmonary circulation basically looks at also the heart, whereby the kidneys, it looks at the lungs and so forth. So when it fails, then there will be a problem. So you realize that somebody's lungs can fail because the heart is not able to release the blood. So the blood that comes from the lungs has nowhere to go. So it ends up causing actually leading to this kind of tachycardia, because the heart is not able to receive anymore. It is already filled and it is trying to force. Then the person starts having those palpitations. The heart tries to pump very fast to compensate. Then the person can even have difficulty in breathing, because now the lungs and the heart are all struggling, and there will be pulmonary edema, accumulation of this blood or these fluids in those different areas of the pulmonary system or pulmonary circulation. So when you look at the causes of the right heart failure, you realize that um, it includes the restretching, the restricting blood flow to the lungs, and then such as pulmonary valve stenosis, pulmonary hypertension, or copulmonale. Copulmonale is just like the failure of the left lung. That's what it means. So when it fails, the right lung, when it fails, then there will be a problem. So this includes those conditions that cause restricting blood flow to the lungs, such as pulmonary valve stenosis, whereby the valves at the pulmonary vein always fail to function, and to cause stenosis, as stenosis is just basically failure of something to function or to flow system. Then the copulmonale is basically the failure of the right lung. So the causes of the left heart failure, it includes the conditions like acute myocardial infarction. It can also be cardiomyopathies. Those are conditions that affect the myocardium of the heart. Then also can be valvular disorders, which affects the valves in relation to the heart and different blood vessels that help to release blood out of the heart. Or it can be rapid infusion of intravenous fluids in patients with limited cardiac reserve. So also this can affect our patients and can lead to the right heart failure. When we keep pumping a lot of fluids to our patients, these fluids will always go back to the heart, and when we are putting a cannula, we put it in the veins. So this can also contribute to a negative impact onto our patients, and this can affect the left heart, leading to left heart failure. Then acute or chronic heart failure. Acute, we very well know, this is a condition that occurs suddenly and it is very progressive. Then the chronic, this one can start earlier and it goes slowly, and by it going slowly or progressing slowly, it causes also more effects and damage to the heart. So we have acute and chronic. Acute is something that happens suddenly. Then chronic, it has been there for some time and keeps progressing. So acute heart failure is characterized by a rapid onset of symptoms and signs of heart failure, often due to acute deterioration in cardiac function. Acute excavating factors may also lead to acute cardiac compensation. So it tries to compensate, the heart tries able to accommodate, and that's why the other time I was saying the compensatory mechanisms, the heart muscles thicken. It tries to thicken in order to have that enough kind of pressure to pump the blood, but when it fails, then it will cause that cardiac overload and the heart will stretch extremely and ends up with hypertrophy, dilatation, and hence heart failure. Then when you look at chronic heart failure, this one represents a chronic state with stable symptoms over time, although acute aggravating factors may cause episodes of acute decompensation. So the chronic heart failure, this one actually the patient has been having the condition, but the symptoms are stable. They are not like the ones of acute, and a person can be with it for some time, as even being managed until maybe sometime when now it develops acute decompensation and ends up with maybe some kind of failure. But now this one, for the case of chronic heart failure, it has been in existence and the symptoms are stable. They are not like the one of acute. So the patient can be with it and the patient can be managed for some time. What are the clinical manifestations of heart failure? There are some manifestations that a patient can present with. We talk about cardiac cohesia. This is severe muscle wasting and weight loss due to chronic heart failure. Most of our clients, they end up actually losing weight. Cohesia is basically a loss of muscles or loss of weight. Someone becomes muscle wasted. You really see somebody like someone who has been having either HIV, and it is because of the chronic heart condition. Then cyanosis, because the heart has failed, especially the left heart failure, and will cause a bluish discoloration of the skin and mucous membranes due to poor load oxygenation. So when there is decreased production or output, then the heart will will not be able to actually perfuse most of the vital organs and also other parts of the body, and then you see somebody is having that bluish color. You just know the person lacks oxygen. And that's when we examine people, the mucous membranes, we see the lips and say, this person's lips are bluish. What is the problem? And then also we can see it maybe in you tell somebody to open their mouth, and then lift the tongue, you check down, you see those blood vessels are somehow blue, that area is blue, then you say, this person has central cyanosis, and that will be a problem with the flow of blood that is oxygenated to the different areas in their body. Then fluid retention can also be one of the clinical manifestations, where there is edema, and this includes the peripheral edema, swelling of the legs and the ankles. You touch the legs, your fingers just enter. And then also the ankles, the same thing. Then ascites is the abdominal swelling, where there is accumulation of fluids around the abdomen. And remember, we also talked about the liver being affected, and this can be also one of the causes that will progress into the abdominal swelling, which is ascites. And then pulmonary edema, whereby the fluid accumulates in the lungs. So pulmonary is basically looking at the lungs, and when the lungs fail to function, then the fluids will get accumulated in the lungs, and this can result if there is a problem in the ventricles, whereby they are not able to release the blood that has been brought into the lungs. After oxygenating the blood, it's supposed to release it, but now it cannot, and it ends up with fluid accumulation in the lungs, causing pulmonary edema. Then shortness of breath, this can be due to the congestion of the lungs. So caused by congestion of the pulmonary circulation, leading to dyspnea, which is difficulty in breathing. So this can make your patient dyspneic. The patient fails to breathe well because the fluid has accumulated in the lungs, and the lungs cannot expand anymore to cause the exchange of oxygen and carbon dioxide. Then also orthopnea, and this is dyspnea whereby it occurs when lying flat and improves when sitting up or standing. So this can also be due to congestive, or it can be due to pulmonary edema, whereby there will be also that difficulty in breathing, and can also cause discomfort to the heart, which can also affect the heart when the patient is next, more a kind of nocturnal dyspnea, discomfort, but when he gets on bed, he starts complaining and saying that he's not feeling well, he's not breathing well when he's asleep or when he gets in bed, often leading to waking up feeling suffocated. The patient will not have a comfortable sleep and always keep waking up. Then chronic dry cough, that is non-productive cough that worsens when lying down, often seen in chronic heart failure. So in chronic heart failure, these patients always present with that kind of cough. Wheezing and difficulty breathing, that is cardiac asthma due to bronchospasms, which is caused by congestion of the bronchial mucosa. So always we know that when there is congestion around the bronchial due to increased secretion of mucus along the lumen of the bronchi, it ends up causing that difficulty in breathing, which is more of wheezing in sound, and that one will be more of cardiac asthma because it is affecting the heart. And this can be also because the heart is the one that is affected, so it is the heart that has caused the problem of difficulty in breathing, and that's why it is called the cardiac asthma. Then chime strokes breathing. This one is characterized by a cyclic pattern of respiration with periods of deep breathing followed by periods of shallow breathing, often associated with heart failure. And then the natriuretic peptides, these are basically hormones that are released by the heart in response to increased pressure and volume, that is used as diagnostic markers for the heart failure. And markers are basically any kind of investigation that you do and it becomes positive, and when you see it, you know that this is it. So a marker is basically one of the I can say one of the standard goals which you can use to identify that someone has a heart failure. So you can look at this natriuretic peptides as a hormone that can be seen in case a patient has a heart failure, and is a diagnostic marker, meaning that it's a baseline kind of test that can be done, not really a baseline as to say, but I think it is like a diagnostic result that you can know that this patient has this condition. You don't have to bring, but it's a key kind of investigation that you can do, and when you see it, you just know this is a heart failure. Also, it involves the clinical assessment. You also need to do clinical assessment on this patient, and you can see some of the signs and symptoms that can clearly tell you that this patient has a heart failure. Then imaging studies such as echocardiography can be done. Laboratory tests including the BNP levels can also be done, and hemodynamic monitoring can also be done in order for you to know or to diagnose this heart failure. Prevention of heart failure. How do we prevent heart failure? Cessation of smoking. Smoking can cause a constriction of the blood vessels, and when the blood vessels constrict, that means that is going to cause resistance in the lumen of the blood vessels, where the heart tries to force blood through those blood vessels because they are constricted, and due to the force that will be exerted onto those blood vessels, it is going to increase the blood pressure because it is trying to flow through the constricted blood vessels, and this can backfire or can get back. Its effect can be reflected on the heart, and this can cause heart failure. Then exercising is also good, but there are some exercises which might be extra for the heart, and therefore we advise that we should not be doing this too much exercise, depending on the age also of an individual. So exercises vary according to individuals and also the age. Then low fat diet, we should not take a lot of fat, because also fat goes to accumulate into the blood vessels, causing blockage in the blood vessels. The lipids, they cause blockage in the blood vessels when they accumulate, and this can also lead to the production of some chemicals, the cytokines, into the blood vessels, and when they accumulate and cause that accumulation of the cytokines, it can lead to either inflammation, which will cause ischemia on the blood vessels, causing rigidity and failure of the blood vessels to stretch, increasing blood pressure along the blood vessels, which will also affect the heart, leading to heart failure. And this can also happen within the heart, blood vessels in the heart, and it will cause what? Heart failure. So the management of heart failure can be basically the overall goals of management of heart failure are to relieve the patient's symptoms. So you realize that these patients have different symptoms that they present with. So our management should be focusing on the symptoms that the patients present with to improve their functional status and quality of life, and also to extend their survival. So when you don't actually manage these patients in relation to the symptoms that they present, then these symptoms are the ones that will kill our patients. Remember, we say that they come with difficulty in breathing, dyspnea. They come also sometimes with increased heart palpitations, and that is tachycardia. So we have to manage this, especially dyspnea, so that our patients can be able to extend their survival. Then also nutritional therapy is one of them, and nutritional therapy whereby we restrict sodium, and you know that sodium leads to accumulation of fluids in the tissues. So when there is decreased elimination of sodium from our kidneys, and this sodium remains in the blood, it causes more attraction of fluids into the interstitial tissues, and that's when you end up with edema. So the sodium restriction is very key for low sodium diet. Patients should not take a lot of sodium, because it will lead to accumulation of fluids. So it reduces fluid retention and congestion symptoms, decreases circulating blood volume, and lessens myocardial workload. So when we looked at the pathway, we realized that when there is decreased release or excretion of sodium, this sodium will end up accumulating in the blood, and it will cause actually it will attract fluids, and when it attracts a lot of fluids, these fluids end up in the tissues, and that's when somebody gets what edema. So when there is failure in the kidneys, our kidneys will always cause us to get this condition, and this is also due to effect from the heart, and that is through the cardiac output. So we have to look at this critically when these patients come. How do we manage them? Let's restrict our sodium intake. They take little salts, or even sometimes some of them may even avoid eating food with salt, or take very very little salt. But some of them, when you tell them the disadvantages, they may even end up not taking salts. So this is what happens in relation to nutrition therapy and in relation to sodium restriction. It is because the causes attraction, it attracts water, and this causes increased volumes of fluids, and which will enter into the interstitial tissues, causing edema. So there will be decreased circulating blood volume. It decreases the circulating blood volume, and also it lessens myocardial workload. So all this is not good for the heart. So they have to reduce intake of what? Of salts, because this can affect the fluids in our bodies. Then patient compliance, vital for avoiding severe heart failure. It is also very key, where the heart failure excavations require hospitalization due to dietary indiscretions. So we also have to advise our patients to comply with what we tell them in relation to either their diet, and also sometimes we need to admit them so that we can monitor their diet and also their vitals. Then in pharmacological therapy, we also have to look at this critically. First of all, we need to know which kind of drugs do these patients need. So these ACEs inhibitors, this is called angiotensin converting enzymes. And when you look at the angiotensin converting enzymes, these are basically drugs that help to inhibit the production of this angiotensin, which is an enzyme. So the slow heart failure progression, and then it enhances exercise tolerance. It also helps to promote vasodilation and diuresis. So vasodilation, it helps to reduce the constriction of the blood vessels, because for it reduces the production of that angiotensin enzyme, which will cause a vasoconstriction. So for it will help to cause a vasodilatation, which is good for the blood to pass through the blood vessels. Then angiotensin 2 receptor blockers, that is ARBs. This lowers the blood pressure, reduce systemic vascular resistance, and improve the cardiac output. So angiotensin 2, it helps to actually a receptor is where this enzyme, the angiotensin 2, will always bind to, and when it binds onto these blockers, it ends up actually inhibiting its activity on the blood vessels, and now it will lower the blood pressure, because now in the presence of angiotensin 2, its effect will lead to increase of the blood pressure if there is no angiotensin 2 receptor blockers. If you don't use these drugs, then it will now cause increased blood pressure. It will also lead to systemic vascular resistance, and it will also affect the cardiac output. But when we have these receptor blockers, these receptor blockers will always block the receptors where this angiotensin 2 would bind and cause an effect on the blood vessels. So for it inhibits. That's why they say a blocker. So it inhibits the binding of angiotensin 2 onto the blood vessels, which will cause vasoconstriction and will end up causing high pressure. So because of these drugs, there will be decreased low blood pressure. It will reduce systemic vascular resistance and also improve cardiac output, because now there will be good vasodilation. There will be also normal kind of pressure, which will not be high in case this angiotensin 2 was able to bind on the receptors. So these drugs, the ARBs, for them they block the receptors for angiotensin so that it doesn't bind on the receptors of the blood vessels, causing an effect to the heart. That's why they call them receptor blockers. Then the beta blockers, this ones reduce adverse effects from the sympathetic nervous system stimulation. So for them, these beta blockers, for them, what they do is just to reduce the effects which would happen onto the sympathetic nervous system. They try to make it to reduce the stimulation of the sympathetic nervous system, which will lead to the production of aldosterone, which will lead to the production of the adrenaline hormones. So for it, it blocks those beta blockers so that there will be no stimulation on the sympathetic nerves, and when it is not there, then they will also fail to produce the hormones that will cause increased blood pressure. Then the diuretics, these ones remove excess fluid by increasing urine production. So diuretic, we have drugs that also are used. And when you have these drugs, they help actually to make someone pass urine in order to reduce the edema or to prevent or to manage edema. So they are called the diuretics. So diuretics, basically, these drugs helps us to give someone pass urine, and when they pass urine, it helps to reduce the accumulated fluids. So it increases urine production, and therefore when there is increased excretion of fluids, it will also lead to a reduction of the accumulated fluids in the interstitial tissues, and therefore it helps us to prevent or manage edema in our patients with heart failure. Then calcium channel blockers cause vasodilation, reduce systemic vascular resistance. So they are contraindicated also in the systolic heart failure. So that's why we need to know the different heart failures that our patients have, so that we can be able to know that which drugs should we use in the management of our patients. So calcium channel blockers, for them, they cause vasodilation. So vasodilation is very important for the blood vessels so that blood can pass through it easily without resistance. So they prevent vasoconstriction, and also they reduce the systemic vascular resistance. And for that case, it is also very key for us to use them, but at least let it not be with patients who are having systolic heart failure. In nutrition therapy, we talked about sodium restriction, which we have already talked about. So I think we cannot repeat this again. We have already mentioned about the sodium restriction, that sodium causes accumulation of fluids into the interstitial tissues. So we should advise our patients to always have low sodium diet in order to decrease the fluid retention and congestion symptoms, which will cause edema in our patients. And also by this, we are able to decrease the circulating blood volume and also lessen the myocardial workload, because when there is increased fluids in the circulatory system, that means even the heart is going to be overworked, because there will be a lot of volume that has to pump out, there will be a lot of volume that has to receive, and that's when now the compensatory mechanism will come in, where now there will be increased kind of the heart tries to make a compensatory mechanism by increasing the thickness of the valves and also the ventricles, in order for it to catch up with the increased volumes of fluids, and this can end up causing us to have that kind of heart failure. So we give our patients advice in order to reduce our sodium diet, and this will help us also to reduce the increased volumes of blood in circulation. Um, these are the types of drugs. We talked about ACEs, inhibitors, and we say that these are drugs that can help us to prevent the accumulation of um, the cause of fluids, increased fluids in the in the system. So when we talk about this, we are going to try to see what are those drugs, what are the ACEs, the inhibitors. These ones are drugs that are used to treat high blood pressure and heart failure by relaxing the blood vessels and facilitating the heart function. So when you use these drugs, they always help us to prevent the production of these enzymes, which will cause vasoconstriction, leading to increased blood failure. So for them, they end up inhibiting the production of aldosterone. They end up actually blocking those receptors where this um, angiotensin would bind. So when you do this, you'll be able to manage your patient very well in relation to relaxing of the blood vessels and facilitating the heart function. So these are some of the drugs, but commonly we use captopril. We also have lisinopril, we have quinopril, and then enalapril. Those are the drugs that I see basically common in relation to the ACEs. So when you look at those drugs, you can be able to tell the common drugs that we have in the market, so that when you're even prescribing for your patient, you should be able to know which ones can my patient easily access, because you can write those drugs and then the patient ends up not getting them. So angiotensin converting enzymes actually for them, they inhibit the production of angiotensin hormones, whereby they fail actually to progress the production of aldosterone, which will cause vasoconstriction, leading to increased high blood pressures. So here they are trying to explain to us how it functions. That was trying to explain to you in my own, but now let's look at the slide. Inhibit the enzyme angiotensin converting enzyme. That's what the ACEs do. And then also they prevent the production of angiotensin 2 and a vasoconstrictor. So it is a vasoconstrictor and prevent the production of angiotensin 2, which is a vasoconstrictor. So for the case of ACEs, they help to prevent the production of angiotensin 2, which would come to constrict the blood vessels in case they bind onto those receptors in the blood vessels. Then also this ACEs try to interfere with the renin angiotensin aldosterone system, which will always be the mechanism in relation to the production of this aldosterone, which will also affect the circulatory system, and will cause more effect into the heart. Then it will result in vasodilation, increased urine excretion, and decreased cardiac output. So this RAS, the renin angiotensin aldosterone system, is always not a good kind of mechanism, because it can result into vasodilatation of the blood vessels, and in case vasoconstriction in case you don't use the ACEs. But when you use the ACEs, this will interfere with the renin angiotensin aldosterone system. Then it will now, when it interferes with them, it will now promote vasodilatation of the blood vessels, then will increase also urine excretion, and will also decrease cardiac workload. So these ACEs are very important because of their mechanism of action, whereby they prevent the angiotensin 2 production, and also they inhibit the renin angiotensin aldosterone system mechanism, and by that they'll be able to cause vasodilatation and increased urine excretion and decreased cardiac output, because they will affect, or they will not allow retention of sodium and water. So there will be good excretion of sodium and water, whereby you will not have that increased amount of sodium, which will cause attraction of water, increasing the circulation of blood in the system, which will also affect or increase the cardiac workload. So these ACEs help us to reduce all this, and the heart will be able to work well, because there will be decreased cardiac workload. Since there is enough or adequate blood in circulation, there will be also decreased kind of sodium ions, which will attract the water in the system, and the heart will be able to pump and function in a normal way to meet the body's demand. So how do you administer this? Oral, it's by mouth. You can also give it intravenous, or it can be given as an inhaler through inhalation solution. Then the various forms allow flexibility in treatment. You can use this for all kinds of patients. The side effects can be headache, dry cough, dizziness, fatigue, nausea, vomiting, confusion, runny nose, and sore throat. So this can be one of the some of the side effects that you can receive in case you're using any of those ACEs. Those are what? The angiotensin converting enzyme inhibitors. What should you need to consider in using these ACEs? Potential interactions with other medications. You should get to know that if a patient is having other drugs, does it affect the mechanism of action of these ACEs? And also monitoring for side effects and effectiveness is very key and should be put into consideration. So angiotensin are providing similar benefits as ACE inhibitors. So the way they function is just like the same. The ARBs, angiotensin receptor blockers, for them they block the receptors. Angiotensin is the one that leads to the production of angiotensin 2 enzyme. Then it also causes the production of aldosterone, and it will cause the effect onto the blood vessels, which will lead to increase in the pressure of the blood flowing through the blood vessels, and this leads back to the negative impact onto the heart. So they almost function the same way, and these drugs are all inhibitors, and some of them are here, and most of them I see being used. Losartan, losartan is commonly used. Even valsartan is commonly used. And which one again? But even these others, you can find them in the market, but they may not be commonly used. But you can see which one is appropriate for the condition of your patient, and which one can your patient be able to afford. But it can help to inhibit these enzymes, which will cause more effect into the blood vessels, leading to a negative impact in the heart. So mechanism of action of this, they block the action of angiotensin 2 enzyme. So when you look at this angiotensin 2, when you look at, it's produced from the liver. Then from here, it goes into circulation. Then it goes and forms angiotensinogens, whereby it now causes angiotensin 1, where it is causes vascular endothelium. Endothelium, it's just it will affect the lumen of the blood vessels, and when it affects the lumen of the blood vessels, it causes something like production of cytokines, and there will be release of the angiotensin 2 enzyme, which will also cause an effect onto the kidneys. And when the kidneys are affected, there will be increased sodium reabsorption into the blood system, which will also increase blood osmolarity, and there will be increase in arterial pressure. Arterial pressure is like increase in the pressures of the blood passing through the blood vessels, especially the arteries. So this angiotensin is not an is a kind of enzyme. It causes a lot of issues in our kidneys in relation to sodium ion reabsorption, causing retention, and this will increase onto the arterial pressures, which will affect the entire circulatory system. Then also it can cause arterioles, where there is vasoconstriction, I've already mentioned, in the arteries, and then also it can increase the PVR and also the BPs. And when it increases these BPs, it will be affecting still the circulatory system, and the impact gets back to the heart. So when you look at this diagram, it shows what happens in the liver because it is produced from the liver, and then in the lungs, what happens? There will be vasoendothelium, vascular endothelium, whereby this the lungs, the blood vessels around there will also be affected, and yet the lungs are supposed to cause perfusion of the, it's supposed to oxygenate the blood. But now when there is an effect on these blood vessels, then there will be difficulty in the lungs to help in the oxygenation of the blood that has been released to them for oxygenation, so that can be taken back to the heart and pumped to the entire body. Then now the angiotensin 2, for it now, it's the one that causes the impact when it now gets into the kidneys, and also it will still affect the heart. After all the effect on the kidneys, it will affect the heart. So when it affects the heart, because it causes increased sodium reabsorption, which will increase the fluids in the circulation, the blood volume, and also it can lead to increased arterial pressures because of the increased blood volume in circulation, which will cause the impact back to the heart. So the heart will try to increase its contractility in order to push that blood that has been released from the blood vessels with increased kind of osmolarity. Then due to this, it will also try to increase on its cells, because now it will try to bring in a compensatory mechanism to help it pump that excess blood that has been released to it, and by that the heart will end up actually vasodilating. So when it dilates, it causes a lot of impact into the ventricles. It causes a lot of impact into the heart blood vessels, which will lead to heart failure. On the side of the adrenal cortex, there it releases aldosterone. Its effect onto the adrenal cortex is where now there will be production of aldosterone, and this sodium will cause reabsorption, and also the potassium excretion. Potassium will be excreted while sodium will be reabsorbed. So when potassium is excreted and sodium is absorbed, that means there will be increased volumes of water being taken in the tissues and in the circulatory system. Then also it increases blood osmolarity due to this sodium reabsorption, and this will increase now the volumes and the pressures in the arterioles, hence affecting the heart. Then still in the kidneys, due to decreased pressure and then also the sodium, it will cause kind of a production of renin still. First of all, in the juxtaglomerular cells. The juxtaglomerular cells are found in the kidneys, and this is in the glomerulus, where there is production or where there is synthesis of urine. So there will be production of prorenin, and because of this, there will be also production of renin, and this renin will be the one that can also cause more impact into the production of angiotensin 1 when it meets, or when these angiotensinogens are released into circulation. So all this mechanism you're seeing here is all because of the effect of these angiotensinogens into the what, into the system. So when this succeeds and there is no use, or I mean there is no impact on this angiotensin kind of angiotensin receptor blockers, then the heart can fail. But in case these drugs are used and they cause an impact by preventing the angiotensin hormone from binding onto the receptors, then this will not happen. So for it tries to inhibit all this kind of effect for it from happening into the heart. But when they bind, then they will be able to cause a negative impact. But when the angiotensin doesn't bind, then there will be no impact onto the heart. So basically, these angiotensin receptor blockers are basically used for the case of preventing the angiotensin enzyme or angiotensinogens from causing angiotensin enzymes to cause this impact onto the blood vessels. That's what these kind of drugs do. For them, they block these angiotensins from causing this effect onto the kidneys, onto the liver, and onto the blood vessels, which will cause a negative impact onto the heart. So the mechanism of action, we want to repeat it here and say result in vasodilation. Vasodilation, it also decreases the blood pressure and increased urine output. So in case you use these drugs, this is what they do. But in case you don't use these drugs and angiotensin ends up being produced, then you're going to realize the impact and the person gets this heart failure. So how do you administer? Administration often combined with other drugs like diuretics or ACE inhibitors. So you combine it with these angiotensin converting enzymes. Then also you can give diuretics, which will help in excretion of the fluids in form of urine. Then oral administration, we give them orally. The side effects is cough, dizziness, fatigue, headache, ankle swelling. So these drugs, always their mechanism is just to block the angiotensinogen from it getting into the circulatory system, and it also inhibits the production of angiotensin. And when it inhibits, then we shall be able also to prevent the production of angiotensin too, and that will prevent the effect of a negative effect that would have caused into the kidneys and then to the heart. So that is the major use of these ACEs. ACE inhibitors, not just ACEs, but ACE inhibitors. So let's look at the beta blockers. The beta blockers are prescribed for heart failure to control our blood pressure and to reduce the heart rate and prevent angina and heart attacks. So these drugs prevent all this due to heart failure. So they try to prevent this kind of conditions or this kind of signs. These are also signs and symptoms that these patients with heart failure present. They present with high blood pressures. They present with increased heart rate, and also they have angina. Angina is pain around the left side where the heart is. So when they give them these drugs, they prevent all this. So they reduce that heart rate, because when somebody has a heart failure, there will be increased heart rate because the heart is trying to compensate. Most of the patients who have also heart failure have high blood pressures. So when you give these drugs, they try to reduce the high pressure, or control the blood pressures. Then also, when they have heart failure, there can be pain on the left-hand side of the heart, on the left-hand side of the chest where the heart is. So when they use these beta blockers, they always try to help to prevent this pain and also to reduce different heart attack conditions. And these drugs can be atenolol, which is commonly used, and then labetalol, I think we have ever used. Propranolol is also one of them, and then metoprolol. Those ones are the common ones that I see people use, but any of this you may easily find them in the market depending on the country where you are and the type of conditions that patients present. That can also contribute to what drugs can be in the market and accessed. So when you look at these beta blockers, the beta blockers, basically they block the action of the adrenaline and noradrenaline. And we said the autonomic nervous system using the effect of the sympathetic and the parasympathetic nerves is the one that causes the production of the adrenaline and noradrenaline for the heart actually to function. So it controls the activities of the heart. But now for the beta blockers, they say it blocks the action of the adrenaline and noradrenaline because they increase actually some of the kind of signs and symptoms in the heart. So for the case of the beta blockers, they decrease the heart rate and force of the contraction. So they try to reduce the effect of this adrenaline and noradrenaline on the heart muscles, and the patient will be able to have at least normalized heart rates, and also will be able to have a normal contractility of the heart. So they help to reduce the blood pressure and improve circulation. So when you have increased production of adrenaline or adrenaline, they cause some kind of increased pressures. And when there is increased pressure in the blood, there will also increase circulation. And this kind of effect will affect the heart negatively. So for this case, the beta blockers will always prevent this in order for them to give a patient have a normal or reduced blood pressure and also improve the circulation of blood in the system. For administration, we give them orally or intravenous infusion, and then also intravenous infusion allows for higher doses. So you can do this in relation to the type of drug or the mode of the type of drug that you're going to administer, and also the state of your patient will dictate which one you're going to give, either oral or intravenous. The mechanism of action, the side effects, it causes fatigue, dizziness, nausea, vomiting, headache, cold extremities, low blood pressure, slow heart rate. Then you can find a patient coming and is telling you, I'm having headache. You think it is high blood pressure, and it is actually the effect of the drug. The common drug also used is digoxin, which is commonly given to patients with a heart condition. But this drug is not an easy drug because it can affect the heart more, or it can stop the functioning of the heart. So digoxin is used to improve heart function for heart failure and contain heart rhythm disorders. So it can affect the palpation of the heart, or the contractility of the heart and its rhythms. So digoxin is a drug that should be used very closely. The patient has to be monitored because its window is very, very narrow. So you need to take care of this patient when you give them this drug, because you can give and the patient ends up again even dying instead of improving. So it increases force of heart contraction depending on how much you've given. So if the patient has heart failure, you can give this, and this can help in increasing the contractions of the heart. Then it slows heart rate because there will be increased heart rate when the heart has a problem, because it is trying to compensate. But for the case of this digoxin, it helps to increase the force of the heart contraction, but it slows the heart rate. So you need to be very careful. It also reduces strain on the heart, as it helps to slow the heart rate and also increase its contraction. So it reduces the strain that the heart will be going through when it is trying to compensate. Then oral administration is based on individual dosing. So this will based on the individual dosing. Monitoring heart rate before administration is very crucial, as I've already mentioned, because it is not an easy drug for you to just give a patient without advice and monitoring. The side effects are there is nausea, diarrhea, vomiting, irregular heartbeat can also occur. And then diuretics, drugs that we give to help the patients actually pass urine. So diuretics are medications used to treat conditions like heart failure by removing excess fluid from the body. And we said when there is a problem uh, in the kidneys, and the kidneys fail to excrete sodium, there will be increased retention of sodium ions, which will cause also increased volumes of blood in circulation, which can cause a heart failure, because the heart tries to compensate to pump that increased amount of blood and ends up straining and increasing its workload, causing dilatation of the blood, I mean the heart muscles. So for the case of the diuretics, they help us actually to remove those excess fluids from the body, hence supporting the functioning of the heart. So it increases urine production, they reduce fluid volume and workload on the heart. And we administer them, like for example, Lasix. We have Lasix in form of tablets and also in form of injectable. Then hydrochlorothiazine also can be one of them. And then caution should be required due to potential side effects and interactions. So you need to know the interactions of these drugs. How do they interact if you give more than one drug to your patient, and what kind of side effects can be there? Are they fatal, or they are minor? So you have to look at that in relation to even this Lasix, because the patient can end up passing a lot of fluids and gets dehydrated, and this can even affect even the heart. um, Side effects also dehydration, as I've already mentioned, electrolyte imbalances, because the patient loses a lot of fluids and those fluids move with a lot of electrolytes, sodium in them, and the patient may lose excess of it, which is also not good, even potassium. Then low blood pressure can also occur due to excess loss of fluids, which will decrease the blood in circulation, causing low blood pressure. Then hyperkalemia, this will now increase loss of the ions. So this comes the end of our session, but I just wanted to recap something small for us to maybe to try to pick up in one way or the other, because in most cases we really need to understand about the causes, and also we need to know how to understand what happens in the right-sided heart failure, what happens in the left-sided heart failure. So for the case of the right-sided heart failure, I want to repeat it and say that this type of heart failure affects basically the lower right heart chambers, and that is the ventricles, and it is called the right ventricle fluids. The right ventricle, which is affected, whereby the fluids may backflow. The fluids we are looking at is basically the blood is what I mean. So there can be a backflow of actually blood into the what into the system, whereby the person will end up having edema, and then ascites, and also it can cause swelling all over the body when there is a backflow. So the right-sided heart failure is basically which receives blood from the body back to the heart on the right hand side for it to be pumped to the lungs for oxygenation. But when this heart fails on that side, that means there will be a backflow, because it cannot function well. It will not accommodate this blood which is returned back to the heart from the body to be sent to the heart for oxygenation. So this blood will go back to those parts of the body in the legs, and you find somebody's having ankle edema, you find somebody's having ascites, just because there is failure of the right side of the heart and cannot accommodate the return of that blood from the body or from the lower extremities. So that is what happens in the right sided heart failure, because we very well know what happens in those different chambers, what kind of blood do they receive, what kind of blood does each side of the heart pump or receive. That's what we need to know also. Then the left-sided heart failure, this one is a type which affects basically the lower left heart, which is the left ventricle or the chamber of the left side of the heart, and it is called the left ventricle, I've already mentioned. So this may cause a backflow into the lungs. So you realize that what happens in these different chambers is basically failure for them to control or to receive the blood that is sent from those different areas which they are supposed to receive from. You realize the left side of the heart, the ventricle, the left ventricle is supposed to accommodate the blood which comes from the lungs and is already oxygenated, and is supposed to pump it through the aorta to the other parts of the body to actually perfuse the other parts of the body. But if it fails, then this blood will have to go back to the lungs and will cause an impact to the lungs. So when the heart fails on the left hand side, there will be backflow of blood back to the lungs, and the lungs will get actually overwhelmed, and will cause shortness of breath, and will cause dyspnea and so forth to the patient or to your client. So when you look at this, you'll be able to understand that when something happens on the left hand side, what is the impact? When something happens on the right hand side, what is the impact? So we need to know all that so that we can be able to know how to handle our patients. And let me see if there is something else. I can also say maybe in the right hand heart, on the right hand side, there is residual blood that is in the left ventricle and can be caused by the left heart failure. So when something happens, or when the left sided heart failure occurs, it can cause an impact on the right hand side and will lead also to the right hand side heart failure. So for the case of the left sided heart failure, it is being initiated by the stress to the left heart, and it can cause systemic hypertension. It can also cause ischemic heart disease, and for this case, the right-sided failure can be as also a result or a consequence of the left-sided heart failure. So for the left heart failure, it can decrease the cardiac output. There can be decrease of the cardiac output because it has failed to release the oxygenated blood. Then it can also cause lowered tissue perfusion because now it is not able to release that blood to the tissues. Then there will be decreased renal perfusion. Renal perfusion is basically look at the kidneys, because I told you this coordinates. So when there is little blood that is pumped from the left hand heart, decreasing the cardiac output, it will lower the perfusion of the tissues, increasing actually cyanosis in those different areas, and there will be decreased renal perfusion. The kidneys will not get enough blood, leading to activation of the renin, angiotensin, and then there will be also a production of sodium, which will be retained and blood into the tissues. So all this is a cascade of issues that can happen when the heart fails. So the major thing which causes all the problem is activation of the renin, angiotensin, aldosterone system, the RAS. That is where all issues will start from, and then it will cause the retention of sodium and then water, which will also cause problems in the pulmonary system, leading to pulmonary congestion and edema. As I mentioned, when you look at the left-sided failure, when it fails, it will also cause an effect to the right-sided right side failure of the heart. Then it will end up being a right-sided failure. So for this, there will be residual blood that will be in the left ventricle, and it is caused by the left heart failure. So I'm just trying to summarize the entire thing. So when it happens in this way, it will lead to increased left atrial pressures and volume. Then when this increases, it will also increase the pressure in the pulmonary venous circulation. Then it will end up with pulmonary arterial hypertension, which will increase actually the right ventricular pressure, and that one leads to the systemic venous congestion, and peripheral edema will occur in your patient. Then you see the patient is having edema on the limbs, lower limbs, a patient is having ascites, and so forth. So just that is a summary that I wanted to say in relation to the different failures in the different sides of your heart. And I also